Bright Nights Community Forum, the Adolescent Brain, Substance Use, Depression, and Recovery, in partnership with the U of M Depression Center.
Hello, everyone. Thank you for coming out tonight. We're going to have a short presentation from one of our addiction psychiatrists who's really doing some incredible work with adolescents and young people. And then we're going to have a panel discussion. But I'm just going to introduce Joanna Quigley. But first, I wanted to tell you that the University of Michigan Addiction Center is a trifold center that focuses on our research portfolio. We have 23 faculty in it. It's in psychiatry, so it's based within the medical school. It has a comprehensive addiction treatment service, which is an intensive outpatient service that we provide some high quality treatment. We have two clinicians, actually three clinicians here tonight, that are actively involved with UMATs. And lastly, we do a lot of education around addiction and substance abuse more generally. You know, 1 in 2 American families are affected by addiction. And you all heard about the really alarming rates of increases in opioids. We're actively researching opioids. One of the things that's relevant for tonight with the adolescent brain development is that we're one of the nodes in the ABCD study, which is a large national study, the Adolescent Brain and Cognitive Development Study. It's a large-scale 10,000 adolescents being recruited from around the country that will be followed for 10 years to understand the development of the adolescent brain, and especially with its focus on trying to understand the development of substance use disorders. We're one of the nodes. We have almost recruited all our sample of 600 12 to 13-year-olds. And we will be following them serially for the next 10 years with brain scans, with interviews, with family interviews, a lot of different things. So we're really at the forefront in doing some exciting work. So Joanna Quigley is a clinical assistant professor in the Department of Psychiatry and received her bachelor's from Carleton College in Northfield, Minnesota, and went to medical school at the University of Nebraska College of Medicine. She's a very unique, special person because she is triple board certified. She's actually boarded in pediatrics, in child and adolescent psychiatry, and in psychiatry. And that combination makes her extremely useful and helpful in all of our treatment programs and everything else that we do. And so I'm really excited that she's here to talk about some basic things about what we know about adolescent brain development and depression and substance use. So, Joanna.
Thanks, everyone, for coming. I see some familiar faces here. So tonight we had a huge topic to try and cover, and I'm making an attempt to sort of highlight really pertinent and useful information, I hope, for all of you. Like they said, write your questions down so that I can answer things and we can all answer together to be as helpful as possible. But we're going to try and look at depression and also substance use related to adolescence. And the substance use part of this, I'm going to focus primarily on alcohol and cannabis, not because kids are not using a lot of other stuff, but just for the sake of time. And also the data that these are the substances that most kids are at least starting out with and using most heavily. So I have no disclosures. And I will present, like Dr. Blow said, for about 20 minutes, and then we'll have a panel discussion. That'll include Dr. Allison Lynn, Lori Schulman, and Charles Graham, and parents who are also here to share their stories with you. So we'll get to that. So what I wanted to try and do tonight was talk about adolescent depression and what it looks like and what we get concerned about, and also touch on suicide, signs, symptoms of substance use during adolescence, related to all of this, why prevention is so important, and how can we respond to adolescence, which I think a lot of that will come up in our panel discussion. So I think this is a question that a lot of parents deal with, and that is one brought to us frequently as clinicians. You know, is my teenager just being a teenager, or is there something more serious going on? And this can be very hard to tease out at times. When do I worry? When do I nag my child? When do I intervene? And this came up clinically for me just in the last couple of days. dealing with two families and their child's suicide attempts, which fortunately were not successful, but both groups of parents saying, you know, I really had no idea things were this bad. And looking back on it, I thought they were just maybe having a bad day because a friend did something or said something, and feeling tremendously guilty. So I also want to touch tonight on why we feel such urgency around mood disorders and substance use in terms of risk for suicide attempts and suicide completion. So I'm going to start with some sort of dry data with numbers, and these come from national data. So in 2016, let me get my pointer going, around 13% of teenagers reported an episode of major depressive disorder in the prior year. This was 8% in 2006, and I've been reviewing some of the data coming out just this year and seeing those rates even higher. Some really dramatic increases in these rates. More females than males might identify as depressed, but that doesn't mean that there's not a very strong preponderance of depression in boys. They're just not identifying it. It's not being seen. They may be kind of a more quiet, angry kid, and they're getting missed. Speaking to the same thing, the prevalence has increased over the last decade, and then looking at the 2015 big national survey of youth, which includes youth from Michigan, the percentage of youth seriously considering attempting suicide increased during this time period, and it has increased again subsequently. So you'll see varying data points around this, but generally suicide ranks as the second or third most common cause of death in those aged 10 to 24. And there's been a lot of recent data about our middle school age kids and how common endorsement of suicidal ideation is becoming for these kids as well. 1 in 5 teens have dealt with at least fleeting suicidal ideation. And we know that the risk of suicide occurring, of someone being quote, successful in an attempt is way higher if they have attempted in the past, and that's why we worry about these kids so much. Generally, males might complete more than females, but we know that attempts are very significant in both genders. So when we look at Michigan and depression, 31.7%, so over a third of Michigan respondents to that same survey in 2015 endorsed feeling sad or hopeless almost every day for 2 or more weeks in a row, which is one of our indicators of potential major depressive disorder. And again, the same numbers are true for Michigan in terms of suicide. These were some sobering numbers from 2015 and 2016. I couldn't find the 2017 data yet, but I think anyone who's aware of what's going on in our community knows that this is a very prevalent problem. So when do we worry? And this is a real tough one for everybody. So I just want to kind of review how we think about depression in adolescence, because in adults, we may think of someone being more classically down, withdrawn, tearful, sad, kind of the more classic depressive symptoms. And what we see in adolescents can be quite different. We can see a lot of irritability, more subtle changes in their engagement with friends or their sleep pattern. And so we don't have to go through the whole list here, but you know, like I said, the irritability, we often see physical complaints, especially in younger adolescents and younger kids, that they'll complain and maybe present to the pediatrician a few times with headaches, tummy aches, other complaints before we really tease out that there's a mood disorder here. Decline in school performance, you know, always thinking about what's going on with a person's functionality, which is different when you're a kid than when you're an adult. And then this hopelessness, which I'm going to talk about a little bit more, which is a really big risk factor for kids over time. And I'm going to touch more on this later, but we do see increased risk of substance use in kids and adolescents who are dealing with depression. So I'm just bringing in some recent media. So this was published back in 2016, but we've seen a lot of similar reports since. So when you look at cause of death, it's now, suicide is now vying up there with motor vehicle crashes and accidents. So I thought it might be helpful to talk about who we worry about with depression and suicide. So we worry about past attempts, like I talked about. And I think a lot of people are becoming more aware of self-injurious behaviors that kids engage with. So you'll hear about cutting or burning, eating disordered behaviors that all fall into this grouping. We really worry when there's a family history of suicide. We worry a lot about risk tied to substance use, and I'm going to get into this more later. In terms of adolescent brain development, the tendency to be impulsive, and then the layering on of substance use really increasing risk. Access to guns, our LGBTQIA minority youth, homeless youth, and I think we can't forget about thinking about our youth who may be on the autism spectrum or have other developmental impairments or delays or just function differently than their peers, and that we've probably underestimated hugely their risks for depression and suicide, and really acknowledging that as very real. So some of this is what I've talked about already, but non-suicidal self-injury, I think, sometimes gets brushed off as a kid just trying to get attention, or it doesn't really mean that they're at risk of doing something more serious, but we do need to take it very seriously. And there was actually a study that came out today showing that within a year after engaging in any of this sort of behavior, the risk of suicide is much, much higher. So I think about it as sort of a prodromal symptom or behavior. So cutting or burning, we get more worried when adolescents are withdrawing from family and friends, their preferred activities. We need to think about safety when we become more worried. So thinking about what weapons do they have access to, what knives or guns, where are medications in the household, whether it's Tylenol or prescription medications. And we also worry more in younger kids about trauma, and that's something that has a huge impact both when we look at substance use risk and depression risk. So again, another list, but I thought it would be helpful for people to see the things that we need to think about when we're worried about self-harm and suicide, but also highlight what's protective, because I think it's really easy to get caught up in all the things that can coalesce to create more risk. So family connectedness and school connectedness, so that feeling of community, that sense of community. Reducing access to means is really important. Feeling safe at your school and having mental health support at school is protective. Academic achievement. So I think this might be considered a fine line, especially where we live, where there's a lot of parental expectation, but not having that sense that your parents are invested in you and how you're doing and in where you're going in life is very protective. Self-esteem, which I think is that nebulous factor in raising kids that you try and promote, but I think temperament plays into as well. Sobriety, which is incredibly important for a lot of our kids in terms of reducing their risk of attempts. Engagement in a faith community. And like I said before, this idea of being hopeful is tremendously important in reducing risk. And this is not very fun to think about, but I think is important to just consider. And this comes from David Brent, who's at Pittsburgh and is one of sort of the national experts on adolescent suicide. And just to highlight a couple things, like I spoke about when we started, that we think it's kind of just normal moodiness, but there was really something more going on. And we still find this to be true, that they'll often say something to a friend, and these days that's really more like sending a text message or Snapchat or some other kind of messaging via social media, but they also asked a friend to keep it a secret. So it's empowering peers, and I think there's a lot of really strong data about how important that is. They'd often made preparations, but also often had trouble with impulsive aggression. And in a minute, I'm going to talk more about brain development in adolescence and how important understanding this idea of impulsivity is to understanding risk. Just to transition here now to talking more about substance use in relation to everything we've kind of built up so far. So I just wanted to start with this chart, which is, unfortunately, my other labeling didn't come up, but this was an interesting study that looked at a group of adolescents that included minority youth, and really trying to look at what factor does self-compassion or self-esteem or valuing yourself have in terms of your risk of depression and substance use, and specifically cannabis use in this study. So they looked at a group who endorsed both high depression and high cannabis use, and this was the age grouping they looked at, so age 14 to 29. And these were scores that they used, so I don't have the full metric for the scoring with me tonight, but essentially the higher score meaning higher use or worsening, worse symptoms of depression. So they found that the kids who endorsed less depressive symptoms also used less, and vice versa. When they used less, they had fewer symptoms of depression. So just trying to give you a picture that ties in this connection between use and mood. So I think this is really powerful, and this comes from Nora Volkow, who is a national leader in the study of substance use, and a very smart woman. And she says, addiction is a disease of adolescence. So I think what understanding brain science has done for us is really appreciating how important it is to understand the vulnerabilities of adolescence for your risk of substance use, both in adolescence and adulthood, and why it is so important to intervene during this time in life. And why is that? We know that the younger an individual is when they start using, the more likely it is they'll have a problem with their use in adulthood. And that's true if you look at alcohol, if you look at cannabis, if you look at any substance in terms of the data that I have seen. So it's very powerful. So what is going on? So brain development isn't just static, right? It continues to go on. The more we understand about brain development, the more it appears it's going on well into our mid-20s. And there's even changes that we see through into your 30s and 40s. So the areas the brain is developing, the brain is sort of tidying itself up during adolescence to become a more adult brain, but certain parts of the brain are ahead of other parts of the brain. I'm going to get to that in terms of impulsivity and risk. One of the parts of the brain that's sort of ahead is the part of the brain called the limbic system, which gives us a sense of reward and pleasure. So that's in high gear in adolescence, but the parts of the brain, like the prefrontal cortex that slow you down, are still getting there, so to speak, and they're really not getting there until you're in your 20s. So this helps explain what we do see, which is adolescents who display novelty-seeking and poor impulse control are at greater risk of substance use disorders over time. So this is more detailed view of that kind of brain modeling that goes on. So we have both increased connectivity in areas of the brain as we go through our adolescent years, and we also have cleaning up, which means a decrease in the gray matter in prefrontal and temporal areas. So we have better communication developing between different areas of the brain, but those areas are still developing and maturing at different rates. So one very simple way to put it is the brain development is going on, but the brakes, that prefrontal cortex area of the brain, isn't quite there yet, while you're starting to understand how great certain things feel, the rush you get with reward. And I think the other thing to remember when we think about brain development and substance use is that adolescents aren't just mini adults in terms of what they use. So you'll see this blue bar is 12 to 17 years of age. This orange bar is 18 to 25 years of age. And then this is the green bar of 26 years and up. So this is looking at a percentage of those who receive treatment for using a certain substance. So you'll see in their younger years heavy use of alcohol and cannabis. And we know this is increasing too, the use of prescription drugs like opioids. But the numbers go up in terms of what folks are seeking treatment for when you get into cocaine and heroin, hallucinogens and inhalants, i.e. that younger adolescents are starting with use around alcohol and cannabis, and it's progressing over time. So I'm just going to touch now briefly on kind of alcohol use and then marijuana use. When we think about alcohol use in adolescence, particularly the alcohol use that brings somebody to our doors, co-occurrence with other disorders is the rule for us, meaning that more often than not, an adolescent is going to be identifying are presenting with symptoms of depression, anxiety, and other mood disorders. And I know I'm kind of repeating myself, but I think it's so important. So alcohol use while dealing with a co-occurring illness like depression increases the risk of suicide attempts, self-injurious behaviors, high-risk sexual behavior, and criminal behavior. And we see this again and again. So the impact of alcohol on the failing brake system is that the brakes have an even harder time working, to be very kind of simplistic about it. And then I'm just highlighting that same point about age of initiation of use. And I don't know if any of you saw, there was a New York Times Magazine article this last Sunday by a writer who talks about her journey towards sobriety, and she starts her piece talking about being 13 and having her first sips of alcohol, and how powerful that was for her and feeling that immediate rush. So not underestimating the impact for someone who's maybe biologically loaded for that first impact of use. So just a couple of points around alcohol use when we think about adolescence. So the one of the groups that sort of sets national standards and gathers the data on this, NIAAA, says no amount of drinking is safe or low risk for under the age of 21. So they're very clear that heavy drinking or any drinking when you're an adolescent is never safe. Part of what drives this is what we've talked about already. Most of those who as an adult are diagnosed with an alcohol use disorder started their drinking by age 18. And we know that if someone's drinking heavily in adolescence, it's highly likely they'll be drinking heavily in adulthood. And what else is going on when you're in this younger age group? You're starting to drive, and the correlation between accidents with adolescence and alcohol use is really, really striking. So when do we get worried about adolescence? Because it's sort of like the comments we sometimes hear about depression. Oh, kids are going to party, they're in high school, they're going to drink, it's not a big deal. But we know that's not true for a number of kids. So what contributes to problematic alcohol use in teens? So the earlier they start drinking, the heavier they're drinking. There's biology to this, which, has been shown in several studies that if you have certain features of a receptor in your cholinergic receptor gene, you have an increased risk of developing an alcohol use disorder when you initiate prior to age 16. So really kind of fascinating that age of exposure for certain vulnerable youth is really key. Parental alcohol use and attitudes towards alcohol use has a big impact on youth. And again, our more vulnerable youth, including homeless youth and LGBT youth. Exposure to alcohol marketing also should not be underestimated, and to remember that that's going on now in a lot of unregulated settings because social media outlets, everything online is not regulated in the same way that we were able to regulate television, which said during certain hours we're not going to advertise for cigarettes or alcohol. That's just not what is going on online. And then again, protective factors. So we know that it does impact kids when they know that their parents disapprove and they have a close alliance with their family. So this is all kind of a whirlwind, but I just wanted to make sure we covered also cannabis because it's everywhere, it's in the media, we know it's in our community, a lot of talk about medical marijuana versus legalization of marijuana. And it's found in a huge number of different forms now. The edible forms you hear about, which unfortunately a lot of younger kids are accidentally ingesting. Really concentrated forms that are sometimes called wax or dabs, the more typical smoking that people are aware of. We'll hear now a lot about cannabidiol oils, so it's a different form of the plant that usually doesn't have as much or any THC and gets marketed as salves or oral medications for certain conditions. But then another big factor is synthetics that we've seen on the market for quite a number of years now, but often have components that may make a person more vulnerable to, for example, psychotic symptoms and are pretty scary. I just wanted to kind of show here the big impact that THC has on the brain because there are receptors that THC binds to throughout the brain and throughout different parts of the brain. So we've got these reward pathways, which really like to eat up the THC, which is where we get that sense of pleasure or the reinforcement to use. It has an impact on balance and coordination. And then, very importantly, mood and memory zones. So we hear about chronic cannabis use affecting a person's ability to concentrate, their memory, and we definitely see an impact on mood and anxiety, and also thinking zones. So kids start to not do as well in school, or they're not as sharp as they used to be, and there is data around following IQ over time, and that there may be an impact in the long run for heavy use during adolescence, literally on IQ scores. And this is just another look at the brain. Again, this reward pathway, the hippocampus and memory, and all the pathways where we know serotonin and dopamine have a role as well, and a lot of crossover with where we just looked at for THC's impact. So all of this overlaps to create what is often a very complex picture when we're taking care of teens with depression and substance use. So just to kind of summarize this, endocannabinoid receptors are one of the most abundant in the brain. So THC has a huge impact through many areas of the brain. The adolescent brain is reward hungry. We are really worried about use during adolescence and long-term effects on brain development. And that it's important to remember, I apologize for the typo, that over time, that reward sort of backfires. And we do see a lot of times that heavy use and chronic use actually reduces a person's ability to enjoy anything. Again, seeing that anhedonic, what we call picture, that lack of pleasure in things, not enjoying things, and not being as engaged. And I thought it would be helpful to just point out a few other things from the data. So adolescents and young adults report low mood immediately prior to marijuana use episodes, and we'll see this a lot with both mood and anxiety, that they use it, they believe, to help their mood or anxiety. And they'll tell people like me that my medicine doesn't work, but cannabis does. So again, that sort of self-medication that you'll hear people speak about. Interesting animal data. So when animals are exposed to marijuana during their adolescent years, that they show more depressive symptoms in their adult years. And that chronic exposure during adolescence may actually affect your ability to process emotional cues. So again, all of these highlighting how vulnerable the adolescent brain is when you start using, and that even if you stop, there may be negative outcomes in the long term for you. So when we talk about treatment, it becomes quite complex in terms of addressing what's going on and addressing it effectively. So as I've said before, dual diagnosis, by which we mean both a substance use issue and a mood anxiety issue, is generally the rule rather than the exception. Oftentimes they might present to us or to their family as just seeming more down or anxious before we realize that there's this other piece going on, which is their substance use. And we have to address both effectively for improved outcomes. When we can do that, or when those both are going on, we raise the risk of treatment dropout. You have a poorer treatment response overall, earlier relapse rates, particularly if you don't treat the depression, mood disorder, or anxiety, that it's harder to stay away from the substance, and they generally require a higher level of care and more treatment services over time. So I put this up here really not to dive into it in detail, but just so that you could all see some of the evidence-based treatments when we're talking about treating adolescent substance use. You'll notice family therapy in a few different modalities, and so it really is so key for that individual's support system to be involved in their care. Cognitive behavioral therapy, which of course you might know of from the treatment of anxiety and depression. Motivational interviewing, which is an evidence-based approach to engaging the youth in care. And there still can be a role for the more traditional 12-step models that are shaped towards more of an adolescent audience. So just like adults, relapse is common, and this is often not a one-shot deal, so to speak, and involves care over time. Rates of dropout can be high. The best predictor of outcomes is that initial level of change after engagement in treatment. And I did just want to mention some of our local resources. There are many more, and there's pamphlets in the area where you came in tonight, and I encourage you to take them with you. And then I have a lot of resources listed here, but just really encourage families and individuals to go and read online. NAMI is a great place to start for resources locally. I'm also on a committee with the American Academy of Pediatrics focused on this. I was formerly on another committee with the American Academy of Child and Adolescent Psychiatry. So you can always look up those professional resources for more information. And then our big kind of governmental national organizations. And I just want to thank Depression Center staff and the library staff tonight, and my colleagues who are going to be on the panel here with me, and my colleagues on this committee, and the knowledge we share, two of whom are Deepa Kamenga and Cheryl Ryan at Yale. Okay, so I think we're going to end here with this formal talk and then transition to our panel. So I think we might start by having everybody introduce themselves, if that's okay, and sort of their role in being here tonight.
Well, my name is Stephen, and I'm a parent of currently a 19-year-old, well, three teenagers, but the 19-year-old who was involved with the therapy program at the University of Michigan when he was 15 and 16.
And my name is Amy, and I am the wife of Stephen.
And I'm Charles Graham. I am a clinician at the University of Michigan's Adult Treatment Services Program, which is part of the Department of Psychiatry. I've been there for about some 6 years now, working with primarily adolescent and young adults who suffer with both primary issues of addiction, but sometimes co-occurring issues along with depression and other psychiatric issues. I'm also an assistant professor at Eastern, where my research focuses on addiction and identity in adolescent youth.
Hi, my name's Allison Lynn. I'm an addiction psychiatrist at the University of Michigan within the Addiction Center and within the Department of Psychiatry. I work clinically, actually, at the VA hospital, working with veterans with substance use disorders, and I also conduct research focusing on how to improve treatment for those who have developed a substance use disorder or an addiction.
And I'm Lori Schulman. I am the social work lead for the adolescent team at the Addiction Center, UMATS. We work with both psychiatric conditions and substance use conditions and their intersection.
So I can start off with the first question, I think asking about one of my initial slides. So asking about that increase in major depression prevalence from 2006 to 2016, how much of this might be accounted for by increased awareness and better reporting. So while that may be a component of it, which I think is often a layer of data that comes out like this, the trends have been so consistent over time, even since 2016, as I said, that there does appear to be something quite real about more adolescents identifying or being identified as meeting criteria for a major depressive episode. I don't know if anyone else wants to comment on that, but and how much of increased depression or suicide might be attributable to the psychological effects brought on by the advent of social media. Which is a great question. This is hard to tease out, but some very smart people have tried to look at this. And I think one snapshot of that comes when you look at bullying and how significant cyberbullying, which I think really encompasses any bullying going on in a social media platform or online or via email, is extremely significant. We've likely been underestimating its impact on kids in terms of their risk of low mood and suicide attempts and suicide. And there is pretty striking data about the impact of this on our adolescent population right now. So it's very real, and I think for myself and for those of us in clinical practice, it's a real challenge to figure out how to screen for that effectively and how to engage youth around that effectively, because at the same time, they consider it a quote lifeline as a social outlet and to have social meaning with their peers. So it's quite difficult.
Yeah, go ahead. No, I was just going to say it's also very difficult for parents to control, as I'm sure you guys know.
I think on the, I guess, slightly more positive side is that in some ways, though, it does offer an opportunity to reach out and engage youth, both adolescents and young adults. I know some of my colleagues at the University of Michigan are actually doing some really interesting research, taking advantage of social media, so Snapchat, Facebook, things like that, because that's where the adolescents are actually engaged, and engaging them and meeting them where they are there, and getting them started to talk about risks of substance use, and really kind of being able to see it from their perspective, but also engaging them around discussing, what are the downsides, what are your worries, and things like that as a gateway into getting into treatment or getting some help for those who are struggling.
Absolutely. See another question coming. Okay. So this question is, I know there is a correlation between depression, anxiety, and addiction and substance use, but is there a possibility that there can be an addiction to the feeling of depression or anxiety itself? So that's a great question. I have some thoughts, but open it up to other folks on the panel.
Yeah, I think the question is good as well, because it's the process of change is difficult, whether that's behavioral change or mood change, and most changes that we make involve some component of reaching out for help, but also some actions that we probably have to take. And so I think changing any state is difficult, whether you would call that addiction or you would call it like a habit or routine. So I definitely think it is a good question.
Yeah, and when we talk about cognitive behavioral therapy, it sort of ties into your question. So that idea that we get stuck in certain cognitions around our mood or our worries, and that those can be very difficult to shift away from over time.
It's just, that brings to mind some research that focuses on identity and identity-induced behavior. And we know that that certain individuals, when they, especially young people, when they particularly identify with a particular behavioral style, if it has been labeled as such, they tend to kind of conform to the expectations of what that role means. And sometimes they're driven more by the concept of what they're behaving in accordance to what either they have been labeled or presumed fits them, as opposed to what their capacity is or the ability to kind of change. And so I think it's sometimes important to kind of see what the role of how they're experiencing their emotions and mood. And I've heard people kind of describe, I'm just a depressed individual. And as a result, that gives them information as to how to act and engage. So I don't know if that's a concept of addiction in terms, but it certainly can give meaning to how should I behave, what's appropriate in my capacity for change. And so I think that's important to kind of hear them in clinical settings to kind of help us understand what the meaning of disorder may mean for them and how they're incorporating it into a sense of self.
This is something I'd hope someone would ask. So if you're concerned about someone's drinking or marijuana use, what's the best way to approach them about your concern? So I think clinicians may have some ideas. I don't know if our parents have some ideas about tackling that, because it's tough.
You can take that.
I can take that on, huh? Oh, boy. Well, I thought it was interesting in your information that you gave out front here. Two things that leaped off the page at me were that intervention's really important, And I forget what the second one was off the top of my head here. Oh, well, the kids really want us to care. They do want us to care. That's what I found with our son anyway. He was extremely resistant to our intervention. And when I say intervention, that sounds so clinical and heavy-handed and all that. It was just that we were concerned and that we wanted his welfare, his best welfare, knowing the facts that you presented tonight. And so we said, we looked around, we found Lori, we found Charles, the UMATS program, and we got him in there. And yeah, he kicked and screamed all the way. But let me tell you what he wrote in a paper that he had to prepare for a class in school some months later. And he wrote that he was really grateful that we had taken him to class because it gave him an excuse that when his friends and his peer pressure was said, hey, come on and do this, come on and do this. And he said, no. That it was so hard when he was before UMATS and that to say no and to have them believe that he meant no. But then when he was in UMATS or when we were doing drug testing at home, he said, I can't because my mom and dad are testing me and stuff. And it gave him a reason, and he felt that was a great relief because he didn't think it was good for him either. I mean, that was my take on it.
Anyone else have other ideas about kind of approaching somebody? Because it's a very hard conversation, I think, to have.
Well, the one thing I can say is it's a place for me as a parent that I never thought that I would be. And it's interesting now because we have a wonderful relationship with our son. But it also, it's interesting to think back at that time because that's not our reality today. And I really owe it to the panel who was very insightful for us and for our son. And he now refers to that as his dark period. And he's glad he's on the other side of it. We have a very witty, energetic, passionate young man, and he's gained a lot of wisdom from that time in his life. And the one thing that Steve and I really worked was to have our home be a peaceful home. We had 2 other kids who were younger, and it was really important that, in a sense, we love our son through this. And we had to stay united as a couple. And I really feel that that strong foundation our son had, as well as the help that he was receiving, was a very large part of him getting on the other side of it.
And I think approach matters. So the question is, how do you approach? I think the first piece is approach. Sometimes that's the difficulty of parents and guardians. They don't want to hear possibly what might happen in the process of approaching. But I've had a number of young individuals who have continued to use and felt like either the figures, the authority figures did not care, did not know, were not curious enough about what was going on in their life to even have the opportunity to reveal and expose the issues. I can remember a particular really quick example of an individual who was under the influence. Parents were kind of looking for him, didn't know where he was. He eventually, our friend called, the parents went to go pick him up, and he was anticipating their arrival and was really worried, like, what are my parents going to do? Something's going to happen. The parents picked him up, took him back home, allowed for him to go upstairs, and didn't inquire at all. And I think they were nervous about what was going on and maybe felt like they didn't want to anger him or whatever, but he remembers that feeling of wanting someone to ask him, you know, what are you doing? Where are you in the process of use? And that didn't happen. And so I think it's really important to approach certainly in a non-judgmental manner with unconditional positive regard and acknowledgement that you're always going to be there for them, that your purpose of hearing them is to support them. But I think the approach really matters, that sometimes we kind of minimize sometimes in the process.
Yeah, and I would just echo what Charles said, that I think sometimes the challenge is that talking about this, mental health and substance use can be difficult for everybody. And I think that's one of the goals that we have here is to be able to talk about it very openly. We know that, the prevalence is high. It's very much present in our community. It's very much present, in the adolescent world. And so I think the first step, like Charles mentioned, is really being able to even ask about it and asking about it very openly. In clinical care, we oftentimes use the term open-ended questions, right? So not necessarily saying, oh, you're not using drugs, are you? But really saying, how are you doing? What's going on? I'm really worried about you, and I wonder if you might be using substances. And that can come from anybody. It can come from parents, and it should come from parents. But it can also, I think, be really powerful when it comes from friends, people at school, just kind of a whole range of people. I think the one thing that is important to also emphasize that, at least for folks either young or old, who've developed kind of more the severe spectrum of what we call substance use disorder or addiction, that one of the symptoms of the illness is actually having difficulty really recognizing it, the impacts on your brain, really causing these behavioral symptoms that makes it difficult to really have them be aware of the problem. And so for all of us to, remember that this is part of the disease itself that makes it hard to really engage this person in the conversation. But in light of that, just, being able to do so, attempting to do so, and being open about it, I think is probably one of the best things you can do.
Right, and I would just add, sometimes when I took from the question, like maybe there feels like could be a difficulty sometimes in starting these conversations. When I, as a clinician, feel like there might be some awkwardness or difficulty, one thing that can be helpful is approaching the topic more generally before jumping to the question, like sort of what substances have you specifically used, who were you with, where were you, and when did it happen? Kind of starting with what substances have you noticed others in your grade using? Have you ever been in a situation that made you uncomfortable? Have you ever related to substances or other issues? But asking, have you ever known anyone that had a problem with substances, and how did you know that the person did? Or have you ever been concerned about somebody else? And I found that those peripheral questions are really helpful in starting the conversation.
This is another really great question for our teens. If they have had a history of substance use, what would you suggest to them if they're planning to attend college with a high drinking culture? And I think that includes just a high use culture. It's a tremendous challenge. I know there's a lot of efforts, even at University of Michigan, to create sober spaces and support for students, but can be very difficult to gravitate there all the time when there's so much around you, around use and partying. And I'm going to let other people respond, but there are certainly colleges that devote floors or dormitories to sober living, and encouraging kids when they're looking at which college to go to, looking at not only the mental health resources there, but the support around sobriety, access to groups, access to individual treatment, because it's a tremendously vulnerable time of transition for adolescents, and a time when we often see adolescents who maybe were dabbling or not using very heavily transition into extremely heavy use during that first year of college, and can suffer tremendously in terms of their success.
Maybe you saw on the Ann Arbor news last weekend that Michigan was labeled the 10th most drunk state in the nation out of the 50 states. And then it said within the state of Michigan, the most drunk locale was in Lansing, where Michigan State is. And I mentioned that to our son because he's been going to Washington all. He's on the dean's list, by the way. And he wants to go to state. And so I said, did you see that? And he said, well, yeah, I know. It's got a reputation of a party school. But he said, but that's not what I'm into, Dad. And, you offered that up and in all sincerity. And boy, as a parent, you go, say thank you for that.
And I think it's also important, we have had several patients who were pre-college age and transitioned from high school into college. And I found it very helpful helping them to develop coping mechanisms well before the actual triggering event, helping to develop what we call refusal skills and practicing it. Typically when skills are practiced ahead of time, it's much easier to utilize them when you're placed in difficult situations. And so offering them an opportunity to maybe even role play or engage in situations that may come up and hear how would you respond if this happened, and what would you do, and what alternatives could you take to avoid either relapsing or engaging in use behavior may be an important thing to do, being proactive in some manner. So
I find that being realistic in the conversation can be helpful. I'll start with that and then I'll add my other thought. But sort of validating the norm of wanting to have a college experience, wanting to have fun. There's this FOMO, fear of missing out. It's kind of a youthful acronym. The people experience, and in general, is validating that substance use serves a perceived purpose for adolescents, young adults, and I think people in general, that this is not sort of usually a malicious intent to hurt other people or hurt oneself, but it's a desire to maybe have fun, fit in, feel better. Mm-hmm. So I think starting with that in these conversations can be helpful. And then just sort of like we talked about before, speaking openly about college, community. There are also a number of collegiate recovery programs at many universities in the country now, which means it's sort of a collective of sober students or students who are in recovery. And they meet, but they also do like yoga and like they had a Halloween party and kind of activities to enhance the fun part of sobriety or abstinence. And I think that's really helpful too. So getting information about that at the college where the person is going.
Any other questions? Anything? Yeah, I was just going to say. So I don't know if any of you want to chime in on what it looks like when people are trying to stop using, to become sober. I kind of talked about it in my slides about relapse being so high, and just similar to adults, seeing people re-engage with treatment many times over at times before they're successful. So.
I have found what it's been pretty enlightening to both parents and youth who are dealing with the process of recovery is the sort of the understanding of the roller coaster experience of recovery, and the appreciation that in particular relapse is not necessarily a sign of regression and failure, but may actually be playing an instrumental role in growth, especially in the way that they respond to their relapse. We have often exposed the parents and youth to this notion of the stages of recovery, and the idea that you have this sort of honeymoon experience initially. Things feel pretty good. maybe after withdrawal effects of the use, things feel pretty good. And then after that really good period comes what we have, it's called multiple things, but we have called it kind of the wall experience, in which people feel significant distress, oftentimes characterized by depression, sometimes anxiety, the anhedonia that was mentioned earlier, and it really takes people by surprise, the feeling that I've invested a lot of time in my sobriety, working really hard, and it seems like it's not working. And it seems like the more I've put in, the worse it's getting. And it would feel better if I just gave up the fight and started using again. And we try to prep individuals to prepare for this stage of recovery by informing them that this is actually a developmental cycle of recovery, and that this may actually be physiologically explained, as well as just a sort of psychological explanation of the body becoming used to the absence of the substance. And if they can make it through that wall period, that very difficult period of cravings and being easily triggered, that there is a bright spot on the other side, and that it really secures the overall long-term recovery if you can make it through without, using and giving in to the process. So I think that I think it's important to kind of understand, I guess what I'm saying is the sort of roller coaster up and down experience of sobriety. It's not a straight trajectory, but it can get better, will get better, the longer one invests in their overall recovery.
Yeah, and I would just say that as a clinician, although I think we've discussed some of the challenges for folks who are struggling with substances, the flip side is actually, in particular, working with adolescents and young adults. You see this level of resilience. You see people recover and just their whole lives can turn around. Thinking about, high school students or even college students who I've worked with, and kind of when you've been able to see them go through this process, really struggle terribly and being very worried about that person having their family, and their parents worry a lot. And oftentimes in the setting of doing good dual diagnosis treatment, which Joanna mentioned, so really addressing both their substance use and their concurrent depression or their anxiety, or other things that are going on with them, and really going through that whole process, and if and when you get to the other end, and being able to partner with that person and seeing them completely turn around, that personality, the resilience, the intelligence come through, that's actually very rewarding. I can imagine it's very difficult when you're seeing folks in different stages before that point. But I think for those of us who've worked with folks who kind of made it through that whole process, it is very rewarding work, but I think it's also important to be able to remind folks that that's possible as well, that recovery is very much possible, that this is a tough illness, but it's actually really amazing when folks are doing well.
And the possibility of recovery is much higher, I think, for younger people than the longer one is into their use behavior. So that hopefulness of getting it early, right, and dealing with it early is a wonderful prospect.
Adolescents and young adults may feel differently about the narrative of the word recovery. It kind of can conjure up one thing for adults, such as 12-step meetings, and a lot of adolescents do use that model and benefit from it. But I find that emphasizing recovery in terms of health, happiness, and safety can be really helpful in engaging adolescents in the process who might not be ready to commit to complete abstinence, even if that from substances, even if that would be the best thing for them.
I think another thing that that Amy and I talked about was, what's causing this behavior? Is there an underlying emotional issue, or are friends coming down on you, or what's going on? And so I think that communication became a what has always been a really big thing in our family. We've always tried to talk to our kids and find out what they were feeling, or, you know, and not being prying or whatever, not make it that obvious, but just through regular conversation and, you know, what's going on. And, oh, you know, the guys on the swim team are coming down on me, you know, they just, I don't know, they're not being nice, you know. What. And so that's something that we need to address then, is what's going on in that area of life that's making things uncomfortable or untenable, that might propel them into some unhealthy behaviors or something, to try and mask that over or take the place of that or make that feel better. So, you know, try to keep on top of that even today. It's an ongoing dialogue. I guess that's parenting, huh? And, you know, we love our kids more than life itself. That's what I always say to them. And they know that. They know that. And, yeah, they're sometimes reluctant to talk, and I'm not. And sometimes my wife tells me, well, you need to just be quiet and, you know, listen to what they have to say. And she's right. So I'll be quiet.
The one thing I remember clearly continuing to say during this phase was, we are a drug-free home. Mm-hmm. And I said that over and over and over again with love and compassion. We're not big alcohol drinkers at our house. It's common to have friends over and not serve alcohol. And our kids really pay attention to that. I think that's another element that our kids watch, how we behave in situations. And that's one thing that's really important to us, is we can have people over and have a great time without the alcohol.
Yeah, so just something to highlight from what Charles said from the biology standpoint, and that can help, I think, folks around someone who's trying to recover, is that very common phenomena of mood worsening or anxiety becoming more intense several months out from trying to be sober. So they may stop and feel like, okay, like he said, there should be this immediate relief and everything is going to get better, and that after that initial boost, there is actually a plunge oftentimes in mood or an increase in anxiety, and that's why the dual diagnosis care is so vital. I guess anything else that panelists think is valuable for folks to take away?
Well, it keeps coming back in my mind. The question that was on the card there is, was it, tell me again, was somebody asking, how do you initially talk to your child about that?
Or to your friend, yeah, just someone you're worried about. Yeah.
And that's kind of stuck in my mind here, and like I say, I try not to be clinical with my kids. First of all, I'm not the expert, you guys are. And I've noticed with our son that when he was using, he's just a different kid. When he wasn't using, we said, he's back. And so I guess when we first noticed that he was gone, quote unquote gone, just, hey, what's up? You know, and just start the dialogue. And that's the hardest thing to do, is to start the dialogue and to be non-confrontational but persistent. Mm-hmm. And find out what's going on.
And remain calm, which is very, very hard in those circumstances. But I really feel it took a lot of work on our parts to really remain calm, knowing if he was going out with friends and knowing the friends that he was with, remaining calm. And ultimately, he had to come around to this decision himself. He had the support from us, but it was ultimately up to him to decide to stop. And after several stop-starts, he did come around to that type of thinking.
So I've got one other question here. Other countries have lower drinking ages. Germany was 14 at one point. Is there something different socially in other countries that might lead to different levels of substance use? So you will hear this argument a lot. The French start drinking when they're younger, or, they don't have this problem in Europe. I don't know the most recent numbers, but binge drinking rates are very high in Europe and a huge problem. And I can speak to, I'm Irish and sort of being aware of the public health issues there. It's been a tremendous issue. And I think it's far more multi-layered than what ages can you start drinking at. It's the culture around drinking, which globally appears to have become more extreme. And when you look specifically at binge drinking, like I mentioned in one of the slides, it's a huge risk factor for future problem drinking. Another thing that you have to remember in Europe when we think about maybe hearing less bad news is that they're not driving as young as we are here. They may be living at home for a longer period of time, so there's some protective factors around morbidity and mortality that are different than living in the US. But just because you're born in Germany or Japan doesn't mean your brain is more resilient against alcohol if you start drinking younger. And that's what you see in the public health dialogue internationally, I would say. So.
I remember spending some time in Canada and talking to just young people in general about their treatment experience. And one thing that was really striking was the ease of access just for healthcare in general. And I know that's not always the case, but that it's definitely an argument for healthcare to be accessible for more people, because it seemed like once the problem was identified, some of these youth in Ontario, at least in that area, had no problem getting involved in residential treatment or inpatient treatment, and really didn't have to worry about financial resources, maybe as much as some of the families that I've worked with here.
And it is different in different countries. And so we travel from time to time. We were in Italy when our son was 16, 17, whatever it was. And one night, he and I went out and had a beer together at 1 o'clock in the morning. And he thought that was so cool. And I said, well, that's what this country's laws are. And so we can have one beer. That's what we'll do. Because like Amy said, we don't drink that much. So we had that, and it kind of, it's that old thing of the forbidden fruit, that kind of thing. I think that's probably what the question is asking. And so I said to him, yeah, in that country, that's what they do at 17. But in this country, we don't. In this country, it's 21. And I said, because we live in this country, that's what we're going to do. And that was the other thing that in your presenting stuff tonight, the second thing that I was trying to remember was that parental expectations are really important. And it's not an expectation of you have to, do right or whatever, but it's, no, we have the expectation that you're going to go to college and finish it, at your own speed or whatever, but you're going to finish it. Or we have an expectation that we're not going to drink in this family when it's breaking the law. No, you're not going to do that with your friends. And it's not a big fight about it. It's just that it's what our expectation is. Now, he may not do that, but that's still what our expectation is. Mm-hmm. And when that's clear, then it does take the pressure. I've seen that it takes the pressure off of him, because he says, I can't do that. It gives him an excuse with his friends. I already said that.
Any other thoughts from anybody? We're getting close to time. Well, thanks everybody for coming. Like I said, there's lots of resources out in the foyer area if you'd like to take them, or feel free to ask us questions too. Thank you.
This program was recorded on March 20th, 2018 at the Ann Arbor District Library.